Have you ever stopped to think about how doctors actually get inside the intricate highways of a human heart to fix a problem they can't even see with their own eyes? I mean, it's this wild world of high-tech cameras, tiny pressure sensors, and microscopic scaffolding. So let's dive into this incredible medical toolkit and figure out exactly how a doctor diagnoses and treats a blocked artery.
It really all boils down to this one big question. A patient comes in with chest pain, right? But how in the world do you get from that single clue to finding a tiny blockage inside a constantly moving organ? Well, that's the journey we're about to go on.
The culprit we're usually hunting for is something called coronary artery disease, or CAD for short. Honestly, the best way to think about it is like the plumbing in your house. Over time, all this gunk, plaque, made of fat, cholesterol, and other stuff can build up and start narrowing the pipes. Well, in your heart, those pipes are your coronary arteries, and when they get clogged, the heart muscle is basically starved of that oxygen-rich blood it desperately needs.
So, where does the investigation even begin? Well, for a patient with what's called stable chest pain, meaning it's predictable, not a full-blown emergency, doctors start with a really clever, non-invasive peek from the outside.
This first step is a special kind of scan, a coronary CT angiography, or CTCA. And this isn't just a random choice. Official guidelines, for instance in the UK, actually recommend this as the go-to first test for patients who aren't in immediate danger. You can think of it as the initial reconnaissance mission. And the reason they start here is, well, it's pretty brilliant. This scan has a kind of superpower. It's incredibly good at ruling problems out. What that means is, if the CTCA comes back clean, doctors can be super confident that there's no major blockage. It's a really efficient way to get a clear no, to answer that key question: do we need to look further, before ever thinking about more invasive tests?
But what happens if that CTCA does show something, or what if the patient's symptoms are a lot more urgent? Well, that's when doctors need to get a definitive map of the situation. It's time to go inside.
And that brings us to this procedure, coronary angiography. Look, this isn't just another test. In the world of cardiology, this is considered the undisputed gold standard. When you absolutely, positively have to see the real-time anatomy of the coronary arteries, this is how it's done.
Now, the process might sound super complicated, but it's actually incredibly elegant. First, a cardiologist threads a very thin, flexible tube, a catheter, from an artery in the wrist all the way up to the heart. Then they inject a special contrast dye. And this dye, it lights up the arteries on a live X-ray video, instantly showing any blockages. It's literally like watching a traffic jam form on a live road map of the heart.
It's important to know that this whole cardiac catheterization thing can be used to explore either side of the heart. For our journey finding a blockage, we're talking about a left heart cath. That's the one that looks at the coronary arteries. A right heart cath is for something totally different, like measuring pressures to diagnose things like pulmonary hypertension. It just shows how versatile this technique is. But for now, let's stick with the left side and that potential blockage. Okay, so the angiogram shows a narrowing in an artery. Case closed, right? We found it. Well, not so fast. You see, seeing a blockage is one thing, but the real critical question is whether it's actually causing a problem for blood flow.
And this is the million-dollar question in the cath lab. Just because an artery looks a little squished doesn't automatically mean it needs a stent. In fact, treating a blockage that isn't truly significant can sometimes do more harm than good. So how do they decide? They need more data. They get that data by looking for this number, less than 0.80. Now, that might just seem like a random decimal, but let me tell you, this single figure has totally revolutionized how cardiologists make these critical decisions. This number comes from a test called fractional flow reserve, or FFR. It's amazing. Using a tiny pressure-sensing wire, doctors measure the blood pressure right before the blockage and then right after it. If the pressure drops by more than 20%, which gives you that FFR value of less than 0.80, that's a clear signal. It's a data-driven red light that tells them this blockage is a real problem and needs to be fixed. And if they want an even closer look, they have these incredible imaging catheters that can literally see inside the artery. IVUS uses sound waves, kind of like a tiny submarine sonar. But OCT, which uses light waves, gives a picture with much, much higher resolution. We're talking microscopic detail here, allowing doctors to perfectly plan their next move.
All right, so the team has mapped the blockage. They've used pressure wires to confirm it's a problem. The diagnosis is done. Now, for the fix, it's time to open that artery back up.
This procedure is called percutaneous coronary intervention,
or PCI. It really is a modern marvel of minimally invasive surgery, because through that exact same catheter they used for the diagnosis, doctors can go right back in and physically reopen the artery.
And the process is just so elegant. First, a tiny balloon is guided to the blockage and inflated, which squashes all that plaque up against the artery walls. Then, a small, expandable mesh tube, called the stent, which was wrapped around the balloon, gets expanded and pressed right into place. The balloon is then deflated and pulled out, leaving the stent behind like a tiny piece of scaffolding to permanently prop the artery open and get that blood flowing freely again.
So when you step back and put it all together, from a simple, non-invasive scan to these incredibly precise internal measurements and repairs, you start to see this complete, sophisticated system for fighting heart disease.
Now, part of this big picture is also being smart about managing risks. And while the procedure is very safe, there can be complications like a kidney injury from that contrast dye. But what's really important to note is that doctors have clear strategies to prevent this. For example, something as simple as giving the patient IV fluids beforehand helps hydrate them and protect the kidneys, making an already safe procedure even safer. And that's really the key takeaway here. Modern cardiology isn't about finding one magic bullet. It's about having this powerful, step-by-step toolkit, this logical journey of tests and treatments that lets doctors see, measure, and then fix problems inside a beating heart with just incredible precision.
And this leaves us with a pretty fascinating thought to end on. We've gone from just seeing a blockage to truly understanding its impact on blood flow. So as these tools for seeing and measuring get even more powerful, even more precise, could we be on the verge of a future where we don't just treat heart disease after it's a problem, but can actually predict and prevent heart attacks before they ever get a chance to happen?